Welcome, everyone. On behalf of the BC Coalition of Nursing Association, I'm happy to welcome you here to our Emergency Opioid Forum. My name is Dr. Jacqueline Keith, and I'm the president of the Association of the Registered Psychiatric Nurses of BC, and I'm your MC for this morning. A few housekeeping rules, if you haven't already found them. The washrooms are downstairs, and those of you that need an elevator, they are over in this area. And also, we have some folk on the conference call, and I welcome you as well. We're looking forward to a great day of discussion and ideas, and very happy that people could come on such short notice. Hopefully by the end of the day, we'll have a good sense of what we need to be doing as a community to better support our frontline workers. And just before we get started, I would like to invite our President-elect Tanya Dick from the Association of the Registered Nurses of BC to bring greetings.
Thank you, Jacqueline. Good morning, everyone. It was really exciting to see this kind of come to fruition today and be able to gather all of us for the issues that we're going to talk about today. So first of all, I'd like to acknowledge the traditional territories of the Tsleil-Waututh, Squamish, and Musqueam nations, the land that we're on, come together to do the work on today. And have really spent a lot of time in this last night and this morning really kind of asking the ancestors to help us with this process because it's such a big issue that we're having to deal with, and we've got to find some answers really quickly. I was asked to speak a bit about myself and my practice as well as doing the basic introduction, the traditional introduction, and I think starting off on a really light note, just recently, well, it's been about 14 months now, I'm a nurse. I've worked in rural communities all of my career, all First Nations communities. My traditional name is Mahwalogo. I'm from the Musqueam people of Kinkom Inlet. My passion has always been, since a child, to want to be able to help my people, and particularly with our health status and the disparities that we face as First Nations people. And there was a lot of influence in my family because my mother was a registered nurse as well. And I think even before I was born, my traditional name and role within our big house system was a traditional healer before I was even born. So it's kind of played itself out and have a foot in both worlds. And it's been really important to me to really work hard and getting the credentials and the education and the skill set to be able to do that back home. So all of my work has been back home, and there's nothing more it's what I've wanted to do all my life, and it's also the most difficult thing I've ever had to do in my life, in providing care for people that I love. And the hard part was that it's been about 14 months now that with a workplace incident, providing services in the emerge department for somebody who I loved very deeply and has been a part of my life, all of my life, came in and was in a very bad car accident, was really, it was a mess, and we had to deal with the body. And basically, long story short, because I only have a few minutes, was diagnosed with severe PTSD from a workplace incident as a nurse providing those services to the people that I love. And I was asked to share that briefly today to kind of start our day because of the importance. We talk about the nurses that are out in the field right now around us dealing with the opiate crisis and the issues that they face daily over and over and over again. And one of the things that I don't want to say pride myself on, but have always relied on was my deep, profound resilience coming from both my parents as survivors of residential school, being born on reserve, growing up on reserve, working on reserve. So I've been around the block and have a lot of street smarts to be able to survive situations that are very, very difficult, and have a really strong network and support system within our community of nursing, and have always walked with me and supported me. So that networking and supported has always been something that's really helped me move forward in my career. And I thought that I was on top of the world, but in a split second, everything fell apart. And I don't think, when I look back on it, that from a preventative perspective that we could have stopped that from happening. But as we dealt through the issue over these last 14 months, we looked at the layers of trauma and exposure and experiences that led to that moment of things falling apart for me. So I think it kind of clicked for me today, and I was excited for today, and I'm excited to go down and meet the people on the front lines. And when we talk about the 4 pillars of approaching this opiate crisis, or overall the addictions and stuff, my question was, what are we doing for our nurses? We talk about the prevention and we talk about the treatment, and we have to have those same sort of systems in place to protect us, because I think in doing what I loved and doing what I worked so hard for, I broke my brain and I couldn't help it, and it just happened. And how do we prevent those types of things? I don't know, but we have to be able to provide opportunities to be stronger and be able as nurses to stop that from happening. We cannot afford to lose any more nurses to PTSD, to being so vulnerable and really breaking. We can't break any more nurses, and we've got to set up systems that protect that from happening. I don't think we need the law enforcement pillar for nurses, but I just wanted to share that with you, that even outside of this, and I know working on reserves is not the same sort of battlefield or playing field or arena that the nurses are experiencing here, but when we expose our nurses to layer upon layer upon layer of trauma and difficult situations, we know what's going to happen, and we have to figure out how to stop that and protect them, and that we don't go down this road that I've had to live. And I still am not back home. I had to move away from my village to get the services that I need to be able to try to get back to work. And my life has completely changed for the worse. But like a phoenix, we're going to come out of this, and I have the supports, and we're going to continue to try and get back on track with that. And I want to get back to work. I'm so proud and of being a nurse, but I think, honestly, in my heart of hearts, I probably won't be able to be an emerge nurse in my own home community again, which breaks my heart. And I think there's a big reality that I may not be able to practice in the front lines again. I won't know that answer until the days pass by. I will be a nurse, it'll just be in a different area maybe, but I don't want any other nurses to go through what I'm going through. And I'd like to find ways today and future days to be able to help that from happening. And thank you for listening to my story.
Thank you. At this point, I would like to welcome some of our guests. We have the president from the Canadian Nurses Association here today, Barb Shellian. Judy Darcy, MLA, New Westminster and Opposition Spokesperson for Health. Sue Hamill, MLA, Surrey Green Timbers and Opposition Spokesperson for Mental Health and Addictions. Thank you. Jenny Kwan, who is the MP for Vancouver East, forwarded a letter to the coalition and for the participants at today's forum, and unfortunately she is unable to attend as the legislation is in this week. It's their last week before for the year, and she has a very lovely detailed two-page letter for us that I'm not going to read in the interest of time, but we will post it up on our website. But there is a paragraph that I do want to read from the letter to you to help spark some interest, and I encourage everybody to go and look at her letter and what she has to say. Jenny says, like so many others, I am dismayed that it took more than a year for the Federal Minister of Health, Jane Philpott, to recognize the gravity of this horrific crisis. BC's provincial health officer declared a public health emergency on April 14th, 2016. And in the intervening 243 days, not only has this emergency state not been lifted, but a number of concerned citizens and organizers, so frustrated by the glaring absence of substance action, have felt compelled to undertake unilateral actions in the face of the crisis. Though unsanctioned, Jenny commends the courage and dedication of those who initiated the pop-up tents in our community as an effort to save lives. She has many other things that she says in this letter, but I'll leave it at that. On December 1st, Mary Lou Gagnon wrote an article in the Georgia Straight entitled "An Urgent Call to Support Nurses on the Front Line of Canada's Opioid Crisis." In that article, Mary Lou called out 3 different organizations, the ARNBC, the BCNU, and the Canadian Nurses Association, for not doing enough to support nurses working the front lines. ARNBC chose to retweet this and ask the question on social media, what more do you think we could do? And numerous responses came in. Go down and visit those nurses and show your support. Came in many times. Another response was bring people together and talk about what to do to support other frontline nurses, give them a forum where they can discuss what needs to happen. That was another topic, and hence today. ARNBC is part of the BC Coalition of Nursing Association, which represents all 60,000 nurses in this province, including licensed practical nurses, nurse practitioners, registered nurses, registered psychiatric nurses, and nurse educators. The coalition had already identified this crisis as a priority, and so we came together, decided we should hold a forum as soon as possible. Right now, I have the absolute pleasure of introducing to you Mary Lou Gagnon, who you could say was the impetus for today. Mary Lou is going to tell you a bit more about why we need this forum and why it needs to happen now, and maybe a little bit about what she hopes we will all get out of today. Mary Lou?
Thank you, and thank you, Tanya, for sharing your story as an ER nurse. That was very, and intense to hear because I can really relate. Maybe not to the extent that you've experienced it, but it's also what brought me to be showing up here in solidarity with nurses on the front line, because I recognize myself and what they were going through, and I recognize in their eyes the compassion fatigue and working under staff, under resources, not feeling heard, not feeling represented. And so this is why I've been occupying this space for a month. And I'm glad that today this is like the beginning of something new, and that there's going to be more leadership in the province to address this. Because ideally it shouldn't be up to a University of Ottawa professor to be leading the response in a province that has declared a public health emergency 8 months ago. So I won't take up too much of the time, actually, because why now? Do we really need to ask the question? I think I want to get the conversation started and leave nurses at the front line that space to actually talk, because they haven't had that space in a year and they've been waiting for it and they need it. So I will leave that time and space for them. And why this meeting? Well, because it should have happened 8 months ago when the province declared a public health emergency. And this is not to blame, it's not to point fingers, but it's to take ownership that that meeting is happening today, 8 months into the public health emergency. And therefore, whatever comes out of the meeting today needs to be fast. This is not the beginning, we're in it. So we don't have the luxury of sitting, at our desk and thinking about what the best strategy is going to be. We don't have a month, 2 months, 3 months. Like, it needs to be fast, and it needs to happen quickly, which means the same thing, but I just want to emphasize that it really needs to move fast, and that this is what I'm hoping from the meeting: concrete actions, direct support, direct consultation to with nurses on the ground, that we don't wait for them to seek out support or fill a form, or we're way past that. This is an emergency and needs to be addressed as such. So I'm glad to be here, and thanks for welcoming me.
Thank you, Mary Lou. And now I have the pleasure of introducing you to a future nurse from Vancouver Community College. Sonia McGoldrick has been working in community health at the Downtown Community Health Centre on Powell Street for several years and has also been involved with the Strathcona community. She and a fellow student did their final project of their public health promotion placement at Sheway, which provides health and social service supports to pregnant women and women with infants under 18 months who are dealing with drug and alcohol issues. You may recognize it as one of the places the Royals William and Kate recently visited during the BC tour. You can read more about Sheway Project on the ARNBC blog, but for now, Shauna is going to perform a song she wrote about her experience, and she will be accompanied by Michael Dunn from the local gypsy band Hot Club of Mars on guitar, and Jacinda O'Dall, who is a vocalist with the City Soul Choir.
We are the women of Sheway, and we can make a change. We are the women of Sheway, and we can make a change. We are strong to the core, we bring justice to the floor. With our babies in our arms, we hold them high and ask for more. There's a mother who's saddling to nurse her babe, and another who learns how healthy meals are made. There are leaders preparing hot food every day, and a team of health providers who help the families on their way. We are the women of Sheway. There's a mother who knows just how to calm her babe, and another who's guiding a child to walk. There are leaders supporting Aboriginal ways. They're a remarkable community that make the royal family talk. We are the women of Sheway. We are strong to the core, we bring justice to the floor. With our babies in our arms, we hold them high and ask for more. We are the women of Sheway. We are strong to the core, we bring justice to the floor. With our babies in our arms, we hold them high and ask for more. There's a mother who knows just how to calm her babe, and another who's guiding a child to walk. There are leaders supporting Aboriginal ways. They're a remarkable community that make the royal family talk. We are the women of Sheway. We are strong to the core, we bring justice to the floor. With our babies in our arms, we hold them high and ask for more. We are the women of Sheway, and we can make a change. We are the women of Sheway, and we can make a change. We are the women of Sheway, and we can make a change. Thank you.
We're going to start with Leslie McBain, who some of you may recognize from your television screen in the provincial government awareness campaign. Leslie founded Mums Stop for Harm after her only son Jordan died from an opioid overdose in 2014. She is a member of the Provincial Opioid Joint Task Force and recently became a team member of the BC Centre on Substance Use, where she works to integrate harm reduction strategies into drug policies and at levels of government. Please join me in welcoming Leslie.
Hi, everyone. Thanks for being here, and thanks for inviting me here. I'm only a nurse in the fact that I am a mom. We're all nurses at that level, I think. Most of you here are well aware of the opioid crisis, and you are the closest to it, close as you can get if you're not family or friends or the drug user, him or herself. If you haven't lost a child to the opioid epidemic, you may not know how I feel. But I have not seen overdose death and harm over and over and over again, so I may not know how you feel. But we can imagine one another's pain, and that's called empathy. And I imagine empathy wears thin sometimes, and I understand that. And that's where, as Tanya said, the PTSD comes in. I lost my son in 2014 to an opioid overdose. He had become addicted to oxycodone, which had been prescribed to him in what I call obscene amounts by our family doctor for a minor back injury. He was a kid at risk anyway, and so it was a no-brainer that he would become heavily involved with this drug. He came to us after about 6 or 7 months of very heavy addiction to oxy, where he couldn't get any more from the doctor and he couldn't find what he needed on the streets, and asked if we could help him get into detox. We did that. When he came out of detox, we could find no support. We couldn't find a doctor skilled in addictions or prescribing Suboxone or methadone, even though we knew about those things. It was about 8 weeks after detox that Jordan died of an overdose of several drugs. Subsequently and consequently, I co-founded Mums Stop the Harm. We're a network of mothers who have all lost children to drugs. About 85% of the women have lost their child to fentanyl. We are the mother bears. We are a network from Manitoba to BC. There's 50 and counting of us who are working for drug policy change in the way of with strategies of harm reduction. When a child dies of a drug overdose, or when anyone dies, no matter what the age, of a drug overdose, something that's preventable, that is accidental, that is stigmatized, it's like a rock hitting a window. There's the shatter pattern, there's cracks, there's shards everywhere. Every single person who dies has potentially 2 parents, 4 grandparents, aunts, uncles, siblings, friends, colleagues, workmates. A whole community is shattered by each death. And the larger community is affected, and the nation is affected by this. So we are indeed in a national crisis that affects every one of us in the heart. This country is in emergency mode. What can we do? Now, I wasn't going to do this, but last night I got a text from a young man in my community who is addicted. He has been kicked out of clinics and ERs because he's a junkie. He has been told, get out of here, you're just a junkie. And so I'm going to read you this text. He says, and his English isn't his first language, so there's a couple of things in here, but I'll read it word for word. He says, I had a friend OD right in front of me last night. When I first hear snoring, I turn my head, and his hands are black. Not like blue, not purple, but black. And his face, his eyes are closed, and mouth, it open wide like a big O. I yell his name and grab him by the shoulders. And he slowly leans forward and falls on the ground. Face black, hands black, shat himself, skin felt like leather. I ran barefoot in the snow to get help to a friend nearby who had the naloxone that you gave me. But I mean black hands and face and the whole shit themselves. I thought he was dead already. They brought him back, but that will never leave me. That's never going to leave me either, because I know this kid and I'm trying to get him into treatment and we can't find anything. What are we going to do about this crisis? BC has the best researchers, the best addictions doctors, the most courageous leaders in our country on this crisis, yet we are far behind and we are running as fast as we can to catch up. It's getting worse instead of better, not for lack of trying. I have the utmost respect for everyone working in this field. So what's going to work? Most of the deaths from fentanyl, all the deaths I would probably say, are from black market fentanyl, unregulated, prepared and put into the marketplace by people who are not professionals, who think they know what they're doing, who really don't care what the outcome is. So the black market for fentanyl is alive and well and growing. I think the only thing, I and my sisters in Mum Stop the Harm think that the only way to mitigate this crisis is to give people who are drug dependent what they need, and that is regulated, clean, pure heroin in a setting that is safe and without stigma. I've thought about this, as we all have, for 3 years now, and I come to no other conclusion. So what I'd like to just leave you with today is that thought. I think when we think it down right to the bottom line, that's where we get. It won't happen tomorrow, it won't happen next month, or it won't happen next year. But we need to look at countries like Portugal and Uruguay and Netherlands and Switzerland and Colombia, places that have actually made these changes and found success in every metric. So anyway, thank you for your service to this country. Thank you for being in the trenches with this epidemic, and may we all leave here with our hearts a little fuller. Thank you.
Thank you, Leslie. Our next speaker on the list was to be Laura Shaver, but she's not here, unfortunately. But Sally is. So Sally Copp, who is a casual nurse at Insight and works on the overdose emergency response team as clinical educator, specifically with overdose prevention and naloxone training. Her current projects include training peers as frontline responders and supporting the new overdose prevention sites with education. So I'd like to welcome Sally up, please.
Hi. So I'm here to talk to you about a few things, in particular our role, what we're doing in Vancouver Coastal Health in response to this opiate overdose response. A little bit of history. The last public health emergency that was declared in the 90s saw 417 deaths in its peak in 1998. Currently we have coroner's data in British Columbia here showing 622 deaths due to illicit drugs, as mentioned fentanyl in particular. That's as of October 2016. And we're expecting the statistics for November and December to be even worse. I won't bore you with too many slides on statistics, but this just shows that the increase in deaths currently in 2016 on the right side of the slide. And this one shows that in 2016, we saw an increase up to 59% of our drugs tested, drug-related deaths containing fentanyl. My colleague Kat's going to speak a bit more on the statistics out of Insight and what we've seen there. But we do know that most of the deaths seen were due to combination drugs, meaning that these were people, and I pause on the word people for a moment, living with chronic addiction. Not addicts, but people. In particular, recently, we are testing for fentanyl through Vancouver Coastal Health, and the big one that has come out recently is carfentanil. So if fentanyl is 100 times stronger, up to 100 times stronger than heroin, and carfentanil is 100 times stronger than that, then you can do the math about, we all know a little bit about chemistry from when we were in high school and, dealing with smaller amounts of things that have higher potency. And that puts us where we're at today. We've seen a rise in deaths this year, in particular over October, November, and December. Recent statistics from Vancouver Coastal Health said that 81% of those were male, and many of them 19 to 39 years of age. This is my age group. This is many of us here, many of our frontline nurse and workers as well. That's our age group. The top sites, particularly here in Vancouver and Surrey, also in Victoria. And you'll know that, we talk about heroin and fentanyl. In Surrey this summer in July, I don't know if everyone remembers, but there was 36 overdoses in one weekend in crack cocaine. So this is not specific just to IV drug users. Many of these people, we also know, are dying indoors and alone. And when it's cold like it is now, this is where people are going to use when there's no other option. I really thank the people who spoke before me, and particularly Leslie, sharing about her son. I've lost 3 aunts and uncles to drug and alcohol addiction, and I lost my uncle to a heroin overdose in 1998. So what are we doing at Vancouver Coastal Health? We can talk a lot about the negative stuff, but what are we doing proactively in response to this? In particular, naloxone training. So this is part of my role as a clinical educator. I have colleagues here from Lionsgate Hospital, from Insight. We are dispensing naloxone kits to those who are highest risk of opiate overdose. We're training nurses to do this, doctors, counselors, opiate users, peers working on the front line, foster parents, and their high-risk youth. We've also developed a map to show where anybody at any time in Vancouver can get naloxone. And this is found both on the BCCDC website towards the heart, as well as on the VCH website. At Insight, we've trained peers who are working on the front line, not only to respond using naloxone, but to deliver education to their peers, other drug users, on how to use that. We've also trained Spikes on Bikes, which is an initiative out of Portland Hotel Society, working alongside us with Vancouver Coastal Health, and peers at Vandu. So I know Laura Shaver wasn't able to make it yet, but they're doing some amazing work there as well. And I really applaud everyone on the front line, especially these peers, for the hard work they're doing out in the cold. As well, we have 2 applications in for supervised injection sites at the Heatley Integrated Health Center and Powell Street Getaway. We've developed overdose prevention checklists for facilities and housing to start the discussion around drug use, so that it's not something we're hiding in the back closet or in locked bathrooms, but creating a dialogue around, what drug use is, where it's happening, and how we can prevent overdoses. We're also teaching on prevention awareness and really integrating that into the naloxone teaching, so that it's not just an intervention as a last-ditch approach, but how can you recognize and prevent overdoses? As well, we're opening we have opened 2 overdose prevention sites. So one of these is at Vandu, and one is right around the corner from the Washington Needle Depot, if anyone knows where that is. And in these overdose prevention sites, we're not really doing anything too different than what's going on already on the front lines. And we talk about the pop-up tents. Really, we're just bringing these people who are providing care out on the streets, out from the cold, into a place where they have their harm reduction supplies and where there's safety and dignity and people to respond with naloxone should the untowards happen in the form of an overdose. We've also this week, you will have seen in the news, opened up the mobile medical unit. This is being run by emergency room doctors and nurses and can be seen as support to places like St. Paul's Hospital, VGH Hospital, Emerge, where they just can't even keep up with all of the overdoses coming into them. The trauma that I hear from my colleagues, other nurses working, that they're experiencing from ambulance attendants, from the police and the fire, is just astounding. So as well, currently with Vancouver Coastal Health, we're working on creating a trauma support system and having some dialogue and sessions for frontline workers in order to take care of their mental health. This is just a quick slide of the inside of one of the overdose prevention sites. And you can see there's good lighting, you know, it's warm. We've got all of these harm reduction supplies we're talking about. And I just want to leave you with a quote, because this is really, for me, sums up what we're doing right now. You know, controversial whether or not the opposite of addiction is sobriety for some people, but I do know that when we're looking at the most important thing for the people that I encounter, it's really human connection and building that connection. And when I train these peers on the front line to deliver this education around naloxone, they're saying the most amazing things to me, particularly that they feel empowered, as well that they feel they get to own their knowledge, that we're sort of reducing this hierarchy of expertise and allowing them to feel like they can take charge of their health care. And the gratitude they're getting, and not every time, right? The vicarious trauma is there, but the gratitude that they're getting from someone when they've saved their lives on the front line is just astounding, and that's what's building community. Thank you.
Thank you, Sally. Our next speaker is Kathleen Gregg, also from Insight. And she has a very informative PowerPoint presentation for us.
Okay, so after all that, I'm Kat. I'm one of the Insight nurses. I've been working at Insight for about 2 years, and I'm here to talk to you today about the impact of the OD crisis on the nurses at Insight, and also a bit about what we're seeing at Insight and what some of our solutions have been. First of all, I wanted to talk to you a bit about the limitations of this presentation. It is going to be very Insight-centric. There are plenty of other groups that really deserve to have their voices heard. I'm just not equipped to give that information now. In the downtown east side alone, we have POS, we have ICMT, we have St. Paul's Hospital, we have shelters and housing, we have nurses at all of those sites. In addition to this, we have non-nursing staff working in shelters, working in the downtown east side, peers on the streets, MDs, NPs, all of them are losing clients in this event. And these people all need our support and deserve to have their voices heard. So I hope that you won't take me as the be-all and end-all of a voice on the opioid crisis. There are plenty of perspectives out there. So I wanted to talk a little bit about Insight by the numbers. Our baseline staffing involves 2 RNs, 5 PHS staff, 2 peer staff, spread over 3 rooms. So we have a waiting room where people come in and they register to use the site, an injection room where people prepare their drugs and injections take place, and there are nurses there to monitor for overdose. We have what we call the chill-out lounge, which is a recovery and monitoring area where people can go after they've completed their injection. They can have a coffee, they can have a juice, they can sit and spend some time, and we just make sure that nothing happens to them. In terms of emergency response equipment, we have 3 crash kits and 3 portable oxygen stations. Our nursing team is pretty small. We have 8 regular RNs, and we have about 5 regular casuals who do a lot of our picking up. So that's not a whole lot of people to manage quite a lot of visits to the site. Now, the role typically of an Insight RN is quite varied. The one that we are most known for is management of overdoses and medical emergencies. That can also include things like chest pain, respiratory distress, anaphylaxis. In addition to these, we provide harm reduction teaching. So we're now doing fentanyl testing drugs for fentanyl, giving teaching around OD prevention and harm reduction, and providing teaching around Narcan and what people need to do after they've received Narcan. Okay, so once you've received Narcan, you need to be continually monitored for another overdose. In addition to these roles, we have less addiction-specific roles. So we assess client needs and we facilitate referrals. So we do a lot of referrals in the directions of addiction services like opioid replacement therapy and recovery, as well as detox. We provide referrals to primary care, so medical clinics, as well as hospitals, and things like dentistry, as well as to other referrals like Shiwei, when we have, say, a client who is pregnant, or to mental health services. We also have a small clinic there, so we have a treatment room where we can provide care like primary care, screening for STIs and HIV and Hep C, as well as other services, so just basic interaction with people, determining what they need, providing medical assessments for people who aren't able to get to the hospital, determining whether people need to go to the hospital, things like that. A very large part of our role as well is working with a marginalized and traumatized population in order to build trust and facilitate their connections to care. We have many, many clients who are just not comfortable going to the hospital and seeking follow-up care because of the stigma associated with drug use and because of their previous treatment. Now, there are a lot of challenges in the Insight role. So what I'm saying here is it's a high-stakes environment, the practice is very independent, and the resources on site are not that large. So we're managing full code blues, respiratory arrests, and our equipment is basically Narcan, a basic crash kit, and oxygen. We can administer oxygen by simple face mask and by bag valve mask, so an ambu-bag, which lets us breathe for someone. We don't have a code team, we don't have MDs, we don't have respiratory therapists, we don't have the capacity for intubation on site. All of these respiratory arrests and overdoses are managed by nurses. This is spread out over, our monitoring of the site is spread out over 13 clients. We have 13 booths in the IR, that's 13 potential injections going on at once, that's 13 potential overdoses. RNs are responsible for the care of all of these clients in the IR, even while we're managing an overdose. So we still, even while we have someone on the floor in respiratory arrest who we're breathing for and administering Narcan to, we still need to be aware of what else is going on in the room. In addition to this, our waiting room and our chill-out lounge contain variable numbers of clients. We are responsible for these clients as well. And in addition to these things, to some extent we attend, sorry about that. If anyone can't hear me, please feel free to just raise your hand. We also attend nearby off-site overdoses when we have the staff and the resources available. So we can't always send staff out into the world to help out with an overdose on the street or in an alley, but we do that when possible. I'd like to point out that having 2 RNs as a baseline means that we only have 1 RN on site when one nurse is on break, or if there is an unexpected sick call or an unfilled vacancy. That is a challenging thing to work with. So what are we seeing at Insight? What's the impact of this overdose crisis? What we're seeing, of course, is an increase in overdoses. This is just a little graph I made from our statistics. Our average between January 2016 and August of 2016, we were seeing about 84 overdoses a month. When you walk all the way to the right-hand side of that graph to November of 2016, we saw 263 overdoses in November. 139 emergency events took place between the week of November 23rd to November 30th. That's actually 8 days, so if you're doing math on that, make sure you're thinking in terms of 8 days and not 7. Most of these events were ODs. That would include some potential chest pain, anaphylaxis, respiratory distress episodes. So we can see that things have increased greatly. And in terms of this number of overdoses, how many do you think were fatal? Yes, exactly. In spite of this tripling of our overdose number, we have still not had any fatal overdoses at Insight. Thank you. That is something we're very, very proud of, but I wanted to point out there's a hidden tragedy in that number, because that means that likely all of these more than 622 overdose fatalities that we have seen in the last year were preventable deaths. That is really a tragic number. A couple of other things I wanted to look at were our consumption of naloxone. We don't necessarily administer naloxone to everyone who is overdosed. Some clients only need physical stimulation, so just someone keeping them awake. Some clients only need oxygen. We administer naloxone only in cases where a client can't maintain adequate oxygenation and respiratory status and oxygen levels over 90% with oxygen and physical stimulation. So use of Narcan indicates that it's actually a moderate overdose that someone is having. And what you can see on our graph is that between February of 2015 and November of 2016, this peak here is November, we had a huge increase in naloxone consumptions. So the average naloxone order in February 2015 to August 2016 was 80 doses a month. In August, we ordered 100 doses. In September, we ordered another 100 doses. In October, we ordered 200, and in November, we have ordered 500. So that's a huge increase in the amount of naloxone that we are requiring. A little bit about our use of bag valve masks at Insight. The use of an ambubag or a bag valve mask indicates that we are actually on the floor breathing for someone. That indicates a potentially life-threatening overdose. So that is a very serious event. This graph here covers our ambubag orders from April of 2015 to December of 2015. Our average was 22 bags per month. From January 2016 to August 2016, so in this last year, we were using 41 ambubags a month, so about a doubling of our order between 2015 and August of 2016. And as you can see, in November of 2016, we ordered 324 ambubags. So once again, a huge increase. That's not the be-all and end-all of all statistics. We have increased our back stock, so we are maintaining more stock in our back room. We are also sharing with other sites because there are other sites who are intervening in overdoses who need to come to us for supplies. But still, that is a massive increase in our order. So what is the significance of this data? I consider it evidence that Insight is seeing more overdoses, that's pretty clear, and also more serious overdoses. This was particularly true over the last three months, so September, October, November. And we also have seen a major increase in October 2016, in November 2016, just relative to October 2016. So things seem to have gotten way more significant just in the last little while. Now, this means a lot more work for us on the floor. What does this mean for our impact on our workflow? This means that we spend much more time managing overdoses. We were managing a couple a day, and we are now managing 6, 8, 10, 20, once 28 per day. So that's over 2 shifts, but that's still a significant number. This means that we are sometimes coping with multiple simultaneous ODs. That is a very challenging situation. That leaves us less time to engage in primary care, teaching, and other aspects of our role. That leaves us less time for charting, less time for managing patient flow, which means that patients are more likely to spend more time in their booths. It also means that we're increasing consumption of our supplies, such as OPAs, NPAs, those are types of airways, bag valve masks, and naloxone. This means that we need to spend more time monitoring our supply levels, ordering supplies, and stocking supplies, which further increases our workload. This situation has also resulted in safety hazards, and events that have been challenging for us. So after every overdose, we need to restock our crash kits and reset our oxygen stations so that they're ready for the next event. Over the last few months, we've had some instances in which, say, I found 2 oxygen tanks that didn't have the sufficient level of oxygen that we expect. We have found oxygen stations that are missing a face mask, or in which the bag valve mask is not set up, or crash kits that did not have the correct number of oral airways. I found 1 crash kit that was missing syringes. These are all really unfortunate, but these are emergencies, or these are events that we really can't prevent when we're just running from one emergency to the next, to the next, to the next. We just don't have the time to keep restocking the kits to the capacity that we need to. This also means that we have less time for monitoring patients post-OD. As many of you probably know, Narcan only lasts for 30 to 90 minutes. That means that's a shorter time of action than any of the opioids out there. That means that someone can actually overdose again within 2 hours without taking any more drugs. So people do need to be watched. It's getting harder for us to do that. When we're going from emergency to emergency, we also have less time for post-overdose and Narcan teaching. So we need to go, when someone's had an overdose, we try to figure out why this overdose happened. Were they using unfamiliar drugs? Were they using more than usual? Were they using a different type of drug? Who was their supplier? That kind of thing. That becomes more challenging to do when we're rushing off to deal with another emergency. This lack of time to recover and prepare between emergency situations is also resulting in increases in physical and emotional fatigue for the nurses. It interferes with our capacity to debrief among staff and determine what we need to do next, what situations are arising on the floor, what may have happened during an overdose that we could have improved or that we could do next time. This also increases our risk of musculoskeletal injuries and needle sticks because we are rushing into a situation that seems very emergent and having to, say, bring someone to the floor or pull someone out from under a booth. We're doing those things multiple times a day. We're also increasing our fatigue because we are sometimes missing our breaks. We're extending our shifts for charting. We're extending our shifts for overtime in the event of a sick call or just because we need to finish things up. Also, I wanted to point out that 2 RNs and our PHS staff, I should mention the PHS is the Portland Hotel Society. They are involved with many projects in the Downtown East Side, including Insight. The staffing levels that we currently have in the injection room doesn't give us a lot of leeway in managing multiple simultaneous severe overdoses, especially in cases where we still need to monitor all of the other people in the room because someone else could be having an overdose at the same time when you're already managing 1 or 2 overdoses. I have recently had an instance where we had one person have a serious overdose. We were managing that overdose on the ground, breathing for someone. The person 2 booths down from them also had an overdose. We were managing him on the ground, breathing with him, so 2 at once, and then the person in between them also had an overdose. So we were managing 3 overdoses in the space of about 5 minutes. I've had 2 overdoses at the same time when I was the only nurse on the floor, and I've heard of a situation where there were 5 overdoses in 30 minutes. So there are some really serious situations that require more people than we currently have. In response to this change in our workload, Insight nurses really came together on this and have been working to increase our own safety. So we've had kind of an unofficial no nurse works alone policy going, in which we try to support each other to make sure no one's on the floor alone. With the increase in ODs, we understand that the IR can't be managed safely, so we have been working overtime as necessary, extending our shifts, picking up additional shifts to avoid single staffing. This is also further increasing our workload, which is already increased by the fact that we have so much going on the floor. And this has resulted in what I call unsustainable heroics, in which people have been putting in way more hours than they can manage. So during November's check week, when we had so much stuff going on, Insight is open for 24 hours between the Tuesday and the Friday of check week. I ended up picking up 1 shift every 8 hours for 5 days in a row. That was 72 hours in 5 days, over nights and days and everything in between. I know of another nurse who worked a 1 a.m. shift till 6 p.m. the next day, which is an incredibly difficult shift, and another nurse in the same period who worked a 15-hour shift one day and a 15-hour shift the next day. So that's really a huge number of hours put into very difficult work. This has also created some impact on our associated sites. Insight has some less famous sister sites, which are On-Site, a detox facility, and CTCT, which provides long-term IV antibiotics to people who, in a residential setting, for people who are using IV drugs. Both of these sites only operate with a single RN and are not capable of operating without an RN. Like Insight, they both have a small team and a small casual pool. For a long time, the result of this was that when there was an unfilled vacancy at On-Site or CTCT, one of these sites would pull an RN to cover them. That has no longer been possible because of the increased acuity at CTCT, so they are no longer allowed to pull Insight RNs. This has further increased the pressure on the On-Site teams and the CTCT teams, which makes things more challenging for them. So how have we been supported in all of this? I'm happy to say that we have received support. Like I said, we are no longer redeploying Insight RNs to CTCT or On-Site. Management has been very good at authorizing workload RNs whenever we request it, or at least trying to get staffing in. That is challenging because of the fact that our team is quite small. Workload RN pay is now covered by the Opioid Crisis Fund, Emergency Crisis Fund apparently, which is nice. We are in the process of hiring an LPN who will be covering all of the hours at Insight so that we will increase our baseline staff by 1 LPN for all hours. We are hiring, if anyone is interested in working at Insight. We have casual positions as well as lines currently posted up. PHS, the Portland Hotel Society, has been involved in creating grief and trauma support groups, and nurses are invited to participate in that. We have been made aware by our management that EFAP and critical debriefing systems are also available to us if we need them. And Vancouver Coastal Health, I understand, is supporting a memorial march for overdose victims that is being planned for hopefully December, although I haven't heard a date on it, and we're running out of December. That's being organized more by the Portland Hotel Society and Carnegie. There has been room for improvement in all of this. As we mentioned, the public health emergency was declared in April of 2016, and we're just starting to see these staffing changes initiated much later. I know that this has been ongoing for a while, but of course these processes take time. Even once you've hired someone, you still need to train them and get them working for you. So it's also been kind of a reactive workload strategy. We're doing a day-to-day call-out for workload. We're not able to schedule staff in advance. Our Insight staff were heavily involved in advocating for an LPN to cover all shifts as opposed to just having a 12-hour LPN, which was the original solution. And I feel that we could have had more support in terms of critical incident debriefing. Now, a bit about the emotional impact of the crisis, which we've already heard some from Sally and from Leslie, but I'll continue on that vein. Like I mentioned previously, the typical Insight RN role is quite complicated. We cover a lot of different areas. This has basically been completely revamped. Essentially, all we can manage right now is overdoses and medical emergencies. We do have a treatment room, but often we have to close it at some point during the morning because of workload, and then provide just work on managing emergencies and providing the care associated with them. This has caused staff frustration because we're only doing a very small portion of what we were originally hired to do. This is also creating distress among us in terms of not meeting our practice standards because of the increased workload that happened so suddenly. We know our charting can be inadequate. You are charting a respiratory arrest essentially when you're charting an overdose, which means that you want to really have enough detail. You want people to know what happened and what you did. It's not always possible for us to make a really good charting. We know that we're not able to provide post-OD monitoring and teaching to our usual standards because we have so many overdoses to manage. And we're always in the situation of having to choose the primary care that we're able to provide. Basically everything that everything that isn't OD management has to be reduced. So for example, we find ourselves having to say no to teaching for take-home naloxone kits, performing wound care in the injection room so that we're on the floor and available to other staff rather than performing it in the treatment room, which of course reduces client confidentiality and dignity, and choosing whether we can perform a brief assessment on someone or if we have to just send them to the hospital, knowing that our client base is often not willing to go to the hospital. We also have to know that our failure to provide primary care in our environment, in our pre-hospital environment, likely increases the burden on the rest of the healthcare system. So if I see someone for a wound that looks quite infected and I'm not able to provide care then and there or facilitate their getting to a hospital or clinic, that wound is likely to get worse. Otherwise, we also have moral distress around our clients' health and safety. So these are clients that we see on a daily basis. We've built trust and rapport with them. We end up watching them leave, that should be the waiting room, not the injection room. We end up noticing that clients leave the waiting room while they're waiting for a booth at Insight in order to inject outside, and we know that that's a very risky activity. So of 170,064 visits for injection room use, 25,895 of those people left due to wait. We know that they're probably going out to inject somewhere else where they will not be monitored. We also are in a situation where we don't always have the resources to attend offsite ODs. We have to say no. That's very distressing because you know someone is seriously in trouble. And we're caring for a community that's increasingly challenged and traumatized. We are experiencing an impact on ourselves. We know that clients are experiencing an even greater impact, witnessing the deaths of their friends and their family members, etc. And we also have to deal with this ongoing fear that this increased workload is going to lead to an event that could impact a client. This could be anything from someone, falling out of their chair, or asking us for an assessment that we have to refuse and having a serious incident happen to them, to having an overdose that we reach too late. We have never had a death at Insight. That's something we're very proud of, but there is always that fear that it could happen. And just having that fear is difficult for us. In addition, we've got an increased risk of personal injury. So we talked about the increased risk of musculoskeletal injuries and needle sticks due to the work that we're doing and the speed at which we're doing it. We are also experiencing just fatigue, exhaustion, illness, and poor self-care because we have a relatively small team that can't keep up the pace that we've been forced to assume. So what kind of support do we need? There are some things that I would really love to see from the nursing organizations that we have. One of the big areas in which nursing organizations can contribute is advocacy, so advocating for safer consumption sites, not just safer injection sites. Injection is the most dangerous route of consumption, but people can overdose from smoking or snorting drugs as well. And because smoking and snorting are much lower risk in terms of infection, we prefer to have the option of letting someone smoke their drugs if they're willing to do that. We could expand access to drug testing. At this point, we can only test for fentanyl in drugs. That means if someone has an overdose and we test their drugs and they test negative for fentanyl, we don't know what caused that overdose. We also know that there are emerging substances like W18 and carfentanil. We have no way of testing for that. We would, of course, like to see more beds for detox, recovery, and supportive housing to help stabilize people. We know, as we all know, there's always a wait list to get into detox. For our population base, which is often people who are homeless and downtown east side entrenched, the barriers to detox that seem insignificant to most people can actually be quite large. So things like transportation, actually getting to your detox, rigid timing, being required to show up at a certain time, delayed initiation, so not being able to get your methadone started on a certain day. All of those things can interfere with people's ability to access detox. We'd also like to see the exploration of additional opioid replacement therapies. So that includes methadone, Suboxone, injectable opiates, as you see in Salome. There are plenty of different drugs and routes that could be explored here, and plenty of better ways for the government to support this. We'd also like to see more support for research. So we only know that these events, that the Insight's role has changed, and that our workload has increased because we've been able to collect these statistics. And because, in this case, I took the time to go through them, along with my supervisor and my clinical coordinator. So we will need these numbers in order to know the impact of the OD crisis on nurses and healthcare. We'll also need to know what's going on in terms of emerging substances. We also want to support teaching, information sharing, and networking amongst frontline staff, because there's always much more to learn. There are ways in which our managers and educators can support us as well. Again, you don't necessarily know what's going on the floor if you're a manager, so it's important to keep abreast of what's going on in terms of your workload, which with relation to the opioid crisis. Ensure that data is being collected, so ensure that if someone feels that their workload is increasing, you have the capacity to find out if that's happening, or to what extent that's happening. Being able to communicate with staff regarding changes in their needs or stresses that are affecting their work. We really encourage ensuring an adequate staffing pool and hiring before there's a crisis, because that's been one of our challenges here, is not that we don't want to work and we can't do the work, it's just that there's so much more work and so few staff to spread it out over. Our workplace has been very supportive in terms of getting additional workers in. We don't need to fight to have workload approved lately, which is great. It also means that an increase in baseline staffing could be appropriate. These events, these overdose events, are really challenging for nursing staff, and it's crucial to ensure that there's appropriate access to debriefing and counseling. When you find someone who is overdosed, they literally look dead. So you see a face that's blue, cyanotic, they're limp, they're unresponsive, and these are people that you know. That's a very, very stressful occurrence. So nurses need support in this area. We know that many deaths are happening, and it's also important to have a plan for supporting staff in the case of a client death. And as we know, our workplace is qualifying for additional funding. It's possible that other workplaces are as well. If you're a manager, you might want to find that out. We can also support each other as fellow nurses. Frontline workers are not the only people engaging with people who use drugs. So there are recreational users, there are youth, there are parents, there are other demographics who don't necessarily meet what we see as traditional frontline nurses. So they are not necessarily people who come to Insight, they're not necessarily people who show up in the ER. They still need education and teaching. So helping to engage those populations would be great. If you are a nurse who's working in a place that is affected by the opioid crisis, it's important to determine your needs for support and relief. Be prepared to bring these concerns to your management with numbers and anecdotes. I find both of those things are very effective. It's really important, I think, to maintain our standards, to avoid accepting a new normal when your workload increases, knowing that it won't let you do adequate patient care. So it is patients' right to receive safe, competent, ethical care. It is our right to be able to work in a situation where we can provide that care. I would like to see us not lower those standards. We can also seek support from our union as needed, it's very good that they're there. And it sounds kind of trite, but it's very important to communicate your needs as an individual and to support each other. We would have had far more challenges in the last month or two if we had not been able to come together as a team and really support each other, figure out what we needed to do, and facilitate making it happen. That's something you can't expect just to come from the top down. So in conclusion, the opioid crisis that we're seeing, it's very real. We know it's been going on for several years. Over the last few months, it's gotten rapidly worse, and it seems that there's been a major increase just in November 2016. We don't know if this is the peak or if it's going to continue to get more challenging for us. Last thing. With a persistent crisis, things to consider are that the fatigue is going to affect the entire work pool. It's not just a question of one nurse being tired, it affects all of us. These increased workload, decreased rest time, and this proximity that we're having to death and grief and suffering all make the emotional impact worse. So those are things that can affect every nurse and affect every nurse differently. All frontline staff, not just nurses, require appropriate staffing, training, logistical support, and also emotional support. We have many organizations that can play a role in supporting frontline nurses and also the non-frontline nurses. So there's a role for the nursing organizations, nurses themselves, and management. And we also want to make sure that people who are not nurses aren't lost in this crisis. We're lucky to have a lot of organizations working on our behalf and a strong union as well. Peer staff do not necessarily have this, have an organization that's so supportive of them. Other organizations might have varying degrees of support. We need to make sure that these people who are having the same challenges as we are not left behind. And that is it. Thank you.
Thank you very much, Kat, in bringing us up to date on what's happening out at Insight. And I want at this time to thank all of the speakers so far, Tanya, Mary Lou, Leslie, and Sally as well.